I would like to invite Dr. Nalinikant Panigrahy, sir. He is a consultant neonatologist and a pediatrician at Rainbow Children's Hospital, Hyderabad. Sir, I would like you to address the participants first, and then we can start with our webinar.
So thank you for a kind introduction, Avali. So this is good afternoon to everyone and the panelists and the delegates. Here we are going with the session with the aim to detect the deviation in the at-risk newborn babies when they are at risk of developing some of the developmental abnormalities later. The aim is to detect it early and to refer in the right time. This module discusses and guides the pediatricians with the simple tools and simple examination findings, how a pediatrician in office practice can identify a deviation and can inform the parents what can be done in the best possible way later. So this video recording is a pre-recorded session by Dr. Eminent neonatologist and developmental pediatrician Dr. Naveen Jain from Trivandrum. And this is a vision of Dr. Ranjan Pejabar, NNF President, sir, Dr. Ranjan Pejabar, sir, and Dr. M.K. Nair visualized this course, and he guided, probably is guiding for last 30 years, many of the pediatricians across country for the developmental assessment. So this is the vision of combined Dr. M.K. Nair and Dr. Naveen Jain. So before going to the session, I will say this is a pre-recorded session. Please attend the session, and after that, three of our eminent pediatricians from the different three states, they will summarize the talk. Later, we can discuss the questionnaire. Now the forum is open for presentation. I will request Abhilizzi probably just to play the video.
Yes, I'll play the video.
Every parent wishes that their child be normal, play like other children,
perfectly fine,
perform the best in their life. As pediatricians, we have the opportunity and responsibility to ensure that every child can achieve his full potential. We often meet parents who are disappointed that their child has a developmental problem. We have found the subject complex and therefore often wait and refer very late. In this program, we will discuss in two modules of 40 minutes each. The first one for babies from 0 to 6 months, and the second one from 6 months to 12 months on how to detect early and refer the babies for appropriate treatment if we suspect a developmental delay. Parents every day wake up expecting the child has learned something new, has started smiling, has started interacting with them, sitting and standing, and saying complex new words. If they discover that their things are not moving normal, or if the pediatrician tells them that there is a problem, they go through the same cycle of denial, anger, and complete depression. The question they ask is, "Doctor, could you not have detected earlier?" Please remember, what we are trying to detect is an infant who is different from most normal babies and not abnormal. The word abnormal should never be used in developmental medicine. The question most often pediatricians have asked us in programs that we conduct or workshops that we conduct for developmental detection is, what next? What if I have picked up a baby with developmental delay? I do not know what to do, where to refer, and often parents and the pediatricians seem to be in a state of anguish as if there is no solution from here on. So in this program, we will take together both the science of detection and simple ways of how to treat these children and help them hand in hand, slide after slide. This great teacher of developmental medicine, Dr. Illingworth, stated that all developmental assessment should happen in the pediatric office, in the outpatient service, with no special room required and no special tools required. Although a specialist may say the child will get distracted, Dr. Illingworth said this is where he is going to perform and this is where he should be tested. The whole aim of this program is to sensitize pediatric colleagues, residents, and practicing doctors and teachers to pick up and treat these children in a simple way. It is by no means a comprehensive document. To completely learn the science of developmental medicine, we may have to refer to a complete textbook of developmental medicine like the Illingworth. Also remember the famous words Dr. Illingworth quoted. In development assessment, we can say something about the child's current state and potential. But what we cannot say is what he will do with it. So none of these items are meant to predict the outcomes of a children in terms of superior intelligence. Although it is the most obvious and the most easy to examine, the head growth is seldom measured in pediatric practice. It's possible that the extreme simplicity in measuring the head performance is the reason why it doesn't get tested. Often an MRI would happen before head circumference is serially measured. Although head circumference may not completely reflect the brain growth, but it is obvious if the brain is growing poorly, the head circumference would also be small. Head circumference should be measured with a non-stretchable tape placed on the forehead and the most prominent part of the occiput passing over both the ears. One must record the head circumference by himself and not delegate it to a nurse or a resident. Each pediatric visit in infancy must have a head circumference recorded and plotted on the growth chart. One must also record the length and the weight and compare the growth of the head in terms of especially the length of the baby. In this graph, you can see the head is also tracking along the centile line, as is the length. Whereas in this graph on my left, the baby's head is failing to grow effectively. The head seems to be static over the weeks. And on the right, you can see a fast growing head that might draw attention to a possible hydrocephalus. In both the cases, the length has been tracking on the line, and it's only the head that has failed to track the way it should. In children with developmental disorders, they may give us clues with risk factors that were already there, but sometimes there are no known risk factors at all. There is complete distress in both the families as well as the pediatrician in how to recognize early in those babies who have no risk factors. Can we pick them up early? That is the question. A serial growth record, especially that of the head, and developmental assessment done in the OP practice for apparently healthy children using a very simple tool would be the way forward. I would propose a 10-second rule. When the family walks into the OPD, straight away do not jump to the reason why they have come, a medical problem, a respiratory illness, a diarrhea. Just look at the child for 10 seconds and listen to what parents have to say, and the child has to act. Ask for the gestation and the birth weight of the baby. Go back to the antenatal risk factors, especially in early infancy, any neonatal problems that were there, and also check the hearing screen report, the thyroid reports, and if the baby is a deserving candidate for ROP screening. Risk factors may be prematurity, asphyxia, hypoglycemia, antenatal anomalies, severe neonatal jaundice, neonatal seizures, and many of them. Presence of a risk factor of this kind should allow you to flag the baby and follow up more carefully. Very often, when the parents are told that there is a risk factor, immediately they get worried. Doctor, is this serious? The question is, how serious or how severe is the risk factor? A very simple common sense approach would say a baby who required resuscitation at birth needs attention. If it was that he required chest compressions and medications, it is even more worrying. And a baby who at the end of 2 weeks of treatment of HIE still remains abnormal, requires tube feeds, gets seizures, is not playful like normal, is more likely to have problems. This kind of severity tag or stratification is going to help in deciding who requires a closer follow-up. We in our unit use a book called as the Blue Book for all these babies with risk factors. But if you do not have one, either you can write to us for a free copy of the Blue Book or simply generate a simple notebook. The notebook's presence in the family's hand will draw attention that this baby has risk factors for developmental delay. So what we learned so far is please measure the head circumference serially for all babies. Flag babies with a notebook if they have risk factors. Do not call them high risk, call them at risk. Calling them high risk will have the parents running away from the follow-up service. Stratify whether the baby is at higher risk or at mild risk for developmental problems, and follow them with a simple developmental tool called the developmental observation card. The whole session today is going to be dedicated to learning of this very simple tool called the DOC, or the developmental observation card. Dr. M.K.C. Nair, the mentor of developmental medicine in India, evolved a very simplistic tool in which he said, please see at 2 months if the child has social smile, has head control at 4 months, sits independently at 8 months, and stands transiently at least at the age of 12 months. Remember to correct for prematurity. If the baby was born at 36 weeks, then you may allow 1 more month before you assess a developmental delay. So the baby should smile at 2 months, have a good head control at 4 months, sit independently at 8 months, and stand at least momentarily for 12 months. At each assessment visit, make sure the baby can see and hear. Further away that the child is from this expected milestone, more is the worry and more likely that the child is going to have problems. Let us first go to a 2-month assessment. At 2 months or 6 to 8 weeks vaccination visit, a social smile should be there. A delay is always a concern. Please look at the picture. Baby is looking very intently at the mother. A social smile involves the baby looking at the mother and smiling in response, in communication with the mother. A smile that the baby gives in dreams, in sleep, or randomly is not a social smile. So absence of social smile at 6 to 8 weeks is always a serious concern. There is no waiting and watching from here. The child may be showing the first signs of global developmental delay with something serious in the brain. Baby may be having hypothyroidism, and even if checked before at birth, it may be worthwhile to repeat the thyroid screen. We must also look for visual problems which may be preventing the child from smiling at the mother. Although red reflex must be done in the neonatal period, if not done before, one must perform the red reflex now. Please note, in red reflex, the ophthalmoscope is kept close to the examiner, to the pediatrician, and not close to the baby. Light is shown onto the eyes, and one looks for equal red responses from both the eyes. And asymmetry draws attention to a problem. What does an ophthalmologist look at if you refer the child to him? The baby may have nystagmus. This may be a sign of serious visual disorder, a clouding cornea, a abnormal red reflex, a cataract. And if an ROP screen is required, whether it has been completed, fundus examination in a term baby after dilatation, and look for refraction. In this picture, you can see a baby with HIE who was being managed, and this baby before that, he was unable to even sit properly. Immature babies, please remember to do complete If there is clouding, keratoplasty can be done to allow light to go in. If the cataract is unilateral, it requires early surgery, and refractory problems like this one can be corrected. If the baby has no visual problem but still has delay in social smile, one would seriously think of a neurological disorder. Such a baby may show a good pupillar reaction, but no tracking to light and no fixation at all. Other markers for early neurological problems that may be that the child does not lift his head in sitting or prone position. You can see that when the baby who is less than 2 months old is made to sit up with a hand supporting the head, a normal baby would tend to lift the head a little bit, at least to the central point, and then there may be a wobble. But a baby with a developmental motor problem may not lift the head at all, like in the red box shown here. You can see this 2-month-old baby who is lying prone on the mother's shoulder. See how he constantly lifts the head.
Full head to
This kind of head lift may be also seen in prone as well as in ventral suspension. In ventral suspension, the baby is held up from the couch with the hand supporting the lower part of the abdomen and chest. And you can see a healthy baby would lift his head and his hands and legs would flex. Whereas a baby with a motor disorder will have his head hanging with no effort made to lift at all. And as well, the hands and legs may hang loose. It is obvious to state that the baby should not be in deep sleep or on anticonvulsants or other sedatives when you perform this examination. A severe head lag like this also indicates a problem. When you try to lift the baby from the couch, normal baby would try to hold the baby head along the line of the body, at least transiently, even as young as 2 months of age. If the head lags completely with no effort to lift, this may be a bad sign. You can see in this picture the posture of a baby who lies normally with his hands and legs flexed and moving completely is a healthy baby. A baby who is lying completely immobile, hands and legs lying loose with hardly any movement is a concern. Also, like the picture on the right, a baby who is lying with arms completely flexed and not moving most of the time, and legs lying in complete extension may be signs of a serious neurological problem. Some other objective signs may suggest either motor or cognitive problems. One is the quantity and quality of movements. I will show you in the next video, as well as the alertness of the child to the surroundings. These are twins who we pictured with their parents' permission, and one baby had more medical problems than the other. Trying to move his hands and legs, whereas the baby on the left, one who was sicker in the ICU, has definitely less quantity of movements, as well as the variability and quality of movements is less. So good movements would be fluent, frequent, variable, and lack jerkiness or tremor. Other early and non-specific signs of a developmental problem may be constant and nagging feeding problems, a baby who has excessive crying that doesn't seem to settle down and brings the parents back to hospital frequently, problems with sleep which do not settle over the weeks, and sometimes a life-threatening event that causes the baby to be rushed to the hospital with choking, going blue, lying still may be signs of a developmental problem. So at 2 months or 6 to 8 weeks visit, the baby should have a good social smile, and a delay is always a concern. He should have some effort to keep his head along the trunk when he is lifted, and a serious and consistent head lag is a concern. Look for quantity and quality of movements. Now, what do I do if I find a concern? Do not immediately declare that the baby has a problem. Reassess after 2 weeks. A milestone that is not improving, that is called persistence of abnormal signs, is more likely to be abnormal. A neurological examination that is still abnormal after 2 weeks in the form of head lag or in ventral suspension, the limbs and the head hanging loose, and a head circumference that doesn't improve over 2 weeks is definitely a worry. Similarly, a baby who had severe asphyxia at birth, requiring chest compressions, and showing combination of signs like poor head growth and severe head lag is of a greater concern than a child who has severe asphyxia, but head growth grows normally, and also fortunately there is no head lag. This child may be better than the previous one. what should I do if I detect a baby with a neurological problem? Of course, I need to refer early to a pediatric neurologist. He may perform an MRI to pick up neurological abnormalities from birth or severity of HI. He may do metabolic tests and genetic tests. We will be discussing them in detail in the second presentation. They would also prepare a list of comorbidities. They may plan medications to reduce the tone, to decrease seizures, to improve sleeping problems, all of which we will discuss again in detail in presentation 2. They may send the child for early intervention to an occupational therapist. Now moving on to 4 months development. At 4 months, the child would have good head control. You can see the baby sitting up in the mother's hand would have a head in midline, which would not wobble. That's what being shown. So these movements, like in the picture on the right side, where the child would head tilt, the child would be having a well-controlled head. He would be alert to sound, alert to the picture close to him, track objects, and have very good interaction with the examiner. So these 3 features would identify 4 months development. So at 4 months, the child should have good head control and should track objects well and turn to sound as well. In addition, at 4 months, the child makes an effort to roll over, and this would require that the ATNR, the asymmetric tonic neck reflex, and the Moro should disappear. ATNR should go away by 4 months. If the baby still shows the sign, then there is a problem. A Moro should be also absent by 4 months of age, and a persistent Moro is a definite indicator that the delay in motor milestone is due to a pathological reason. By this age of 4 months, the child keeps his hand open for most of the time. So a hand which is fisted, a hand which does not open up, is a serious concern. At this age, you may label a baby as high risk of cerebral palsy. You may not use the word cerebral palsy by itself. So there will be a child who has delay in motor milestones, like having poor head control, not rolling over, persistence of primitive reflexes like the ATNR or Moro, poor hand use, hypertonia and hyperreflexia, a small head, and setting of risk factors like extreme prematurity or asphyxia to begin with. For hyperreflexia, when you elicit a knee jerk, it is abnormal not by the size of the jump of the leg, but on how far from the patellar tendon that you can elicit the knee jerk. So if you go to the shin and still get the knee jerk, it is not good. And if you can elicit even from the ankle, then definitely the knee jerk is abnormal. Hypertonia in the lower limbs would be shown by a tight adductor angle. You can see less than 60 degrees. Even crossing of legs may be seen. And hypertonia of the upper limb can be picked up by looking at the scarf sign. In the scarf sign, you hold the wrist of the baby and try to pull across to the opposite shoulder. What you're noting is how far the elbow would go. Normally, the elbow would cross the anterior axillary line on the same side and move into the body line, like here. So the elbow would lie somewhere between the 2 sides of the body. But a hypertonia of the upper limb would not allow the elbow to be pulled in and therefore would not cross the anterior axillary line. At 4 months, we told baby should be very keen, alert, and looking at an object. You can see the baby looking at the red ball. Also, he would be trying to reach out and track the object. You can see in this picture, the child is very alert, keen, and playing with me at 4 months of age. And when he is shown an object, a torch, which is not lit up here, just for the red color, you can see how keenly the child is trying to follow the object. So you don't need any special tools. At 4 months, when the child comes for vaccination visit, do look for a good head control and also whether the child can track to good height and if the child is not listening, then there is a concern, and even a baby who has passed the OE previously should undergo a BERA testing and be referred early for a hearing aid by 6 months of age. So a keen, alert baby who tries to catch an object, who sits requires the child to be able to track sounds, track light, and have a good head control. Absence of these should alert you to the possibility of visual problem, global developmental delay, or a delay. Once again, head steady, holds objects in hands with hands open, and looks and turns around for objects. So what we have told so far, or summary of detect at 2 months, is the child should have a social smile. He should lift head with no lag at all. When just tried to pull to sit, he should have good movements. And at 4 months of age, the child should track and turn to both light and sound. He should have a good head control, try to roll over, and have a good hand use. Besides brain factors, there could be medical reasons for developmental problems. One must do a hip examination at every visit in an infant. Currently, we do not recommend hip screening in newborn, and therefore it's very important to screen for hip dislocation on follow-up examination. Asymmetrical abduction, not able to completely abduct flexed hips, is a sign of a dislocation of hip, and you must refer to a pediatric orthopedic specialist. He may completely once again examine and confirm that by ortho-Lanin test he can't seem to put the hip back. X-ray will confirm the dislocation, and the child may require a harness to protect the hip from damage. There may be other problems like a meningomyelocele, need not be only with the leg without a meningomyelocele, and the one having hardly any movements on the one bit spinal cord. These two together, not seen the normal twin. We don't train our eyes for normal. We may sometimes fail to be sure without an MRI whether the baby has social defect or not. So please remember, we need to take the medical and neurodevelopment care and assessment together. It might be looking very complex. We are asking you to do a risk stratification and listing, do an eye examination, ROP check, plot the head growth, do a neurological examination, do immunization for all these babies. Is it possible? Will I forget? Will I miss? So a simple way to do this complex care is to have pre-printed leaflets or booklets. We have this in a book called Blue Book, which we're willing to share with anybody who mails to us. Thank you for your attention for the first session. That this program is only meant to sensitize pediatricians to pick up developmental delay and refer early. This is by no means a comprehensive program. One may have to study a development book like the Illingworth to be able to pick up developmental delays comprehensively. Also that the aim is not to predict future outcomes, but only to find infants who may benefit by early referral and treatment. By 6 months, babies are extremely exciting and playful. They interact with the child, with the parent, with the pediatrician. They reach out for toys, grasp them, and transfer from hand to hand and to the mouth. And the mnemonic goes that by half year, they're able to say half words. They have babbling, social babbling. They're able to say something in their baby language. You will see in this video that the infant is able to reach out for the toy, which is a pen in this case, to take it to the mouth and to the other hand. You can see how playful, keen, and attentive the baby is to the object that is there. This is an important milestone for the infant to be able to reach out for the objects that are being offered to him. Not reaching out for the toy by 6 months of age should make one suspect that there is a problem either with vision or the child has a serious problem with his brain development, with milestones failing in more than one domain, what we call as global developmental delay. The problem may be one of early cerebral palsy, where both programming and execution of motor function may not happen. We may have an opportunity to look for asymmetry, and maybe a pointer to hemiplegic cerebral palsy or problems like Erb's palsy. As you saw in the video, the child was very alert, interested in everything around, responsive to the call of the mother, and concentrating on the objects he was trying to reach. These have been called as insurance factors. Presence of these wonderful interactive signs make us assured that the child does not have global developmental delay and his social development is good and unlikely that this child will have autism spectrum disorders. Now we get back to our CDC grades, the development observation card. The 8-month milestone is that the infant should be able to sit well for some time. You can see in the picture that we had at 2 months the requirement that the baby should smile. At 4 months, the infant was able to hold his head well, and by 8 months, he should be able to sit well. The picture on the right shows a cartoon and a picture of a baby who at 8 to 9 months can sit steadily with the back straight, can pivot around and look around. If the infant has to take support on his arms or tends to prop forward, this is not a mature form of development for an 8-month-old baby. When we put the baby in sitting position, if he tends to fall back periodically, repeatedly, tends to pull up his legs and knees because of hamstring spasm, they may suggest diplegic cerebral palsy. An infant who can sit with the back straight, head in control, and the legs easily spread out is a good baby. Not being able to sit may either be cerebral palsy or maybe a local neurological problem like that one of the hips or that of the spine. We will see these two videos on how infants are sitting at 10 months of age. In the first video, you can see that this young baby is sitting with back tending to get rounded, head tilted to one side, and he is wanting to play with the pen but is not independent. He tends to lean forwards, and the parent is worried that he might fall and tends to give support to him periodically. In contrast to the young child we saw in the previous video, you will find a child same age who is able to sit very confidently with a straight back, happily playing, see the free use of his hands, with a good head control. He is able to turn around, pivot, complete freedom. And there is no anxiety in the parent that the child may fall down. They're sure about his sitting. I'll show you the previous video once again. You can see this child who is also sitting up, but he tends to lean forward, head is tilted, back is rounded, and even though the child wants to use his hands and play well, the child is unable to do so. He is always tending to lean forward, and the parent is trying to hold him because they feel that he might fall over from their previous experiences. So, maturity of good sitting includes not just being able to sit, the child should sit with a straight back, good head control, be able to pivot around and play well with the hands. One must also observe that the head tilt by itself may be a sign that may indicate that the sitting is not mature. This mother brought this child to me because the child was keeping head tilted most of the time. One must also be reminded that single signs should not be used to make diagnosis of neurodevelopmental problems. If you carefully observe, this infant has a very good pincer grasp. He is able to hold head അങ്ങോട്ട് tilt ചെയ്യാൻ tendency ഉണ്ടോ എപ്പോഴും with her hand with thumb and fingers together, index fingers together, and able to even freely exchange the object to the other hand. This made me reassured that possibly the head tilt is an isolated sign and may not be an indicator of cerebral palsy. In fact, on follow-up, the child was all right under development. This picture I borrowed from the CDC milestones. You can see a mature pincer grasp. The infant is using his thumb and index finger to pick up a small object. This requires good hand-eye coordination and therefore is a effective test of his vision, his brain cognition to be able to reach this object, and motor coordination. So in one test, you can check all the three functions together. It is understandable that at 9 months, if you do not have a good pincer grasp, the problem may be due to refraction, cerebral palsy, or global developmental delay. By this age, a pediatrician may often forget to ask about prematurity, and an accidental age calculation can label the milestone wrongly. So do correct for prematurity before you say the child has developmental delay. Motor function requires good coordination both from the brain as well as the muscles. If there is cerebral palsy, the child cannot reach out to the target, he misses the target. In this case, a baby elephant placed on the table. Also has a splayed approach because of lack of coordinated movements of the hands, which require flexion and holding of the object. Splayed hand approach and missing the object is a definitive marker for cerebral palsy affecting the upper limb. We must also look out for asymmetry, which becomes more evident as the child gets older. In this picture, the child is reaching out for an object with the right hand, the knob of the door, the slippers on the floor, but is unable to use his left hand effectively. It is fisted in the hemiplegic posture. He can't draw the left leg also into a well-flexed position because of a spasm of muscles. This is diagnostic of hemiplegic cerebral palsy. By 9 months of age, we are also able to evaluate an important developmental milestone, that is social development. Children start waving tata and bye-bye. They would affectionately say mama and meaningfully, not just the sound. They would also start developing anxiety to strangers. They can differentiate self from other members. Joint attention means the ability for the baby to join the point of attention drawn by the mother. If she points the finger to the fan and says fan, the child looks up towards the fan and associates the word fan with the object shown by her mother. If this is not there, learning process will not happen and may be the first pointer for autism spectrum disorders. If a child does not have any back and forth play with the mother or lacks a joint attention completely, one must be concerned. Please remember, if both parents are busy at job and the child is confined to a mobile phone or a tablet game or a television, what we call as gadget overuse, and doesn't have opportunity to interact with human beings, they may develop symptoms similar to autism spectrum disorders. We just talked about the ability of the child to learn playing with the mother. You can see in this video that the child has what is called as cause and effect play. He knows that if he presses the button of the torch, the light would go on. So he is able to connect these two functions. In fact, he's looking up for the fan in my office, which was not there because of being in air-conditioned room. The parent had asked him, where is the fan? He's able to point the torch and look at the light dancing in my room. So this is called as cause and effect play. A similar example may be a child pulling at a string, knowing that the toy would come to him. He's very active, playful, almost fidgety. Now you compare this child's activity, interest, keenness, looking around, and trying to do things like switching on and switching off the torch, with the other child on the opposite side who is hardly moving. I'm showing him an object, a dangling tape, which he doesn't seem to be interested to reach out to and hold. He's looking at the tape, all right, but doesn't make efforts to reach out by moving his hands. Generally, his body movements are less. They lack interest, attention. This child has very high risk of developing global developmental delay. So by 8 to 9 months, the child can sit well. If he does not do so, with a straight back, with good head control, with well spread out, easy to place legs, I must suspect cerebral palsy or local pathology like hips or spine problem. The child should use his index finger and thumb finger together to get a good pincer grasp. Suspect there are problems of vision or any other neurological disorder if you can't do that at 9 months of age. By 9 months, we are evaluating a new domain of development, that is social development. The child should interact and play. He should have joint attention. Absence of these should make you suspect that there is autism spectrum disorders. We mentioned about refraction testing. The RBSK India recommends testing of refraction for all preterm babies by the age of 6 to 9 months. How it is done is classically by a method called retinoscopy, in which light is shown into the eye, and if there is normal power, it would fall exactly on the retina with a good focus. What you would find is an image on, like you see on the left side. If there is a refraction problem, then you would see a different image which moves either along with or in opposite directions in the eye as the object is moved. This would indicate that there is a refractory problem. Then one places a lens to correct this movement of the object and finds out the correct refraction. It is understandable that this process is difficult to execute in small children. Therefore, you may use something called photorefraction or autorefractometer. This is a device recommended by American Academy of Family Physicians for office practice. All you need to do is show the camera to a child who must focus towards you for just a few seconds, maybe 5 seconds or more. And then the camera would capture the refraction, squint, and all other problems for the eye and show you the values. It can be done for children more than 5 months old. Now our infant is 12 months old. Let us see what we expect the infant to do. He should be able to stand momentarily, at least for a few seconds. We can see in this video that there is a baby pushing the chair, stably able to walk with the chair forwards. This is a good stand development. Whereas in the video on the right side, you can see an infant who is much slower, seeking support of the chair all the time, standing on her toes. And this infant is unable to push the chair around. In fact, she has to seek the support of her mother merely to just be able to turn around. And even when a mother helps her to walk, you can see the gait is not stable. So there is a great difference in the development of standing milestone at the age of 12 to 13 months between the two infants. The reason for not being able to stand at 12 months can sometimes be familial. Infants with large head and a relatively small body, which is common in India, may be the only reason for the child not being able to stand independently. Such infants will have no other signs of motor disorder like hypertonia, toe walk, or hand use problems. Of course, this may be the first sign of cerebral palsy. The problems may be in the hips or even in the spine that the child is not able to stand. The other important milestone you would note by 12 months of age is the use of index finger. The child can point at objects with his index finger. He can use his index finger to explore toys. Absence of this milestone should make us again doubt that he cannot see well, refractory problem, or has a global developmental delay, or maybe a cerebral palsy evolution. The child should now be able to say at least one meaningful word. Also, he should respond to mother's name call. So the mnemonic is half word, that is a babble at 6 months, and one word at 1 year. This is an important language milestone that we should monitor. Some children speak late. This may be a familial trait, so we must always ask family history before we decide that there is a problem. The most important thing to be excluded when there is a language delay is to exclude hearing problems. Of course, global developmental delay and poor social development in autism spectrum disorders may be the cause for delayed language as well as respond to name. So by 12 months, the child should be able to stand independently, at least for a few seconds, use his index finger to point to objects and to explore objects with the index finger, say at least one meaningful word, respond to name call, and have a good cause and effect play like we saw in the video previously. We now sum up the important milestones of the detect and treat program. By 2 months of age, the child should have a social smile. So look at the mother, should respond to her call, should smile well, absence of which makes us worried. The child should be able to lift his head in prone and in ventral suspension, but should have no head lag. By 4 months, they keep the hands mostly open, grab an object that is placed in the hands and use the hands well. They would have good head control and try to roll over. The ATNR reflex and the Moro reflex would be gone. By half year at 6 months, they should say half words, babbling. They should be very keen and attentive, reach out and grasp toys, exchange between hands, take to mouth. These are important milestones. By 8 months, the child should sit without support, with a straight back and good head control, and should pivot and play without falling for some time. The knee should not be pulled up and tense. The child would develop stranger anxiety. This may be the first sign of development of cognition and social milestones. By 9 to 10 months, the child plays. He would say tata, mama, and develop joint attention, looking at an object that the mother points to and recognize the name that the mother is giving the object. These signs may be absent in a child who has autism spectrum disorders. Pincer grasp requires the child to pick up a tiny object between the thumb and index finger. This requires motor coordination starting from the brain, may be absent in cerebral palsy and in global developmental delay. This also may be the sign of poor refraction or visual problems. By 1 year, that is 12 months, the child should say one word, respond to name call, and stand without support, at least for a few seconds. Now, all these detect and treat programs are meant to pick up Neuro-Developmental Disorders. The common ones that present in infancy mostly have feeding problems as common, whether it is cerebral palsy or a global developmental delay. We must also pay attention to correctable factors like refraction, hearing and speech problems, and hips problems. A child who has late motor milestones, persistence of primitive reflexes, high tone and exaggerated reflexes, sits with a rounded back even by 8 months, has his hands fisted most of the time, has a splayed approach to objects, a small head, feeding and swallowing problems, in the presence of risk factors like asphyxia and prematurity, may be actually having evolving cerebral palsy. A child who shows poor interest in surroundings, no social interaction like social smile, joint attention, language delay, and tracks no sound or light may be a pointer to cognitive problems, global developmental delay. The question is, what can we do to help this baby? Please do not think that it is all dark. Surely there is light at the end of the tunnel. The first thing we need to do is have a team meeting. In the team meeting, of course, the most important person is the family, the pediatrician, and the specialist that we may require based on the listing of morbidities and comorbidities. Is the problem related to hearing? Is it a visual problem? Is it a motor problem? Orthopedic problem? We need to involve all these specialists and clearly define their problem. We need to set goals that this family needs to achieve over the next few weeks and months. One of the commonest problems with infants is that of poor feeding and drooling. A speech and language pathologist can help in achieving these solutions. The other problem we may see is a motor problem, like in cerebral palsy. We have moved beyond mere referral to physiotherapist. The family needs to be told that the child does not have a milestone, like head control or sitting, and we need to plan the therapy so that we can achieve this motor milestone. Give them a goal, as in how many months or weeks we can do this and how we intend to do this. This is called target-oriented motor training. A neurologist may prescribe baclofen for severe hypertonia or may use a botulinum toxin in spastic hypertonias. This infant received 2 shots of botulinum toxin in the calf. This allowed the tone to be reduced for a few months, during which effective occupational therapy without causing pain to the infant was possible. In hemiplegia, we may use a program called constraint-induced movement therapy. In this program, the infant's weaker leg is encouraged to be used by restricting or preferentially offering the games from the side of weakness. In this video, you will be able to see this hemiplegic infant who has been offered an ankle foot orthosis on the left side. This allows the fixed contractures to be corrected and the child would have a better gait. You see that he has left hemiplegia. Parents have taught him how to improve the hands by doing things like clapping. The child can walk around with a little different, but it was not possible without the use of the. You can see his preferential use of the right hand. The speech language pathologist we were discussing can help in many ways. A child who is choking to feeds may be allowed to feed slower by interrupting the feed coming from the bottle, what is called as spacing. They may be able to offer low flow teats because frequent chokings causes discouragement to both the baby and the parents and sometimes failure to gain weight as well. An ophthalmologist may correct refraction, allowing the child to learn from his environment. Squint not corrected in time may result in amblyopia. We may require medications for seizures, for hyperactivity. We may have to address sleep problems, which are very, very common, causing difficulty not only to the infant, but even to the family when it is a long-standing issue. Co-contraction, that is simultaneous contraction of the opposing muscles of the body, is a common feature in cerebral palsy because of poor inhibition of opposing muscles. This causes constant pain, and we may have to address this in these children. There are many medical issues that need to be paid attention to. Many of the vaccines we deem as optional are very important to cover for all infections. Children who have constipation, reflux, or other nutritional challenges may have to be helped for these. In the worst cases, they may have tracheostomy for airway problem or gastrostomy for severe feeding problem. These children require special care. Skin damage is common because of tone abnormalities and pressure points that these children often have. We cannot forget the parents of this special child. They need to be given clear information on what is the current problem and plan. If they do not know this, they cannot move forward. We need to help them with coping behaviors to understand that even if there is a difficulty, it can be helped. Often parent support groups of children with similar problems make it easy for the parents to ask questions that they cannot get answers for from doctors and nurses. They need psychological support. Entity called secondary retardation involves that if the baby is poorly dull and active, then he does not stimulate the parent. The parent gets bored that the child is not active. In turn, the parent does not again stimulate the baby, resulting in loss of potential. The child may have emotional problems because he wants to play, his mind is active, but his body doesn't follow him. We may have to recognize and address these psychological problems in the child and in the parent. How do I ensure that I do not miss these problems? Remember, in the first session, we discussed about a notebook. We flag the child, list his problems, list the goals, note down the recommendations of specialists, and also follow them up systematically. The pediatrician has to remain the nodal person for the child with special needs. He may take the help of a development therapist or a nurse. Most often we hear from a busy pediatrician that how do I find time for these children? You may have to fix a day of the week or a slot of the day to be able to give more time to these children and families. This is another peculiar problem that these children and pediatricians face. Where can I find these specialists? You may not know all of them at one go, but as you practice, you will refer a child to one specialist or the other. Please note down every time you found a specialist, his contact details, his visiting time, and the hospital where he works. This will help a family who is already strained with a disabled child to coordinate their visits easier. You have to find out an ROP expert, an audiologist, where is BERA done in your city or nearby, EEG, MRI, ortho, especially one with pediatric interest, an occupational therapist, a speech language pathologist. Where is hearing aid being made in your neighborhood? Where can you get genetic advice and metabolic testing done? One more challenge we have in this COVID times is how to call children for development testing. This has been made possible by an innovation that we have found in our unit. We send them the ages and stages questionnaire on the day prior, which is for the age appropriate assessment, and then through half an hour each. At least try to have a list of those conditions which you should never miss because they're very easy to treat and may change the life of a child. Hypothyroidism, hip dislocation, refraction disorders, hearing impairment are completely amenable to therapy. We learned very, very simple things that can be done in a systematic way. Remember the words 2, 4, 8, and 12. Flag babies who have risk factors with a simple notebook. Offer simple screening programs like thyroids, hearing, ROP, and hip screening throughout infancy. Plot the growth, especially that of head circumference. Record milestones, social smile at 2 months, head control at 4 months, sitting at 8 months, and standing at 12 months. At all visits, assess vision and hearing. Do a physical examination for medical factors that can be corrected and pointers to cause of developmental delay. Neurological examination has been made easy through simple signs that we demonstrated in these pictures. Please remember, we all can help a child to achieve his full potential. Let us detect developmental deviation and aim to refer early and act timely. That is to treat infants. This program will be successful only if each one of us decides to remember the 4 magic words: 2, 4, 8, and 12. Thank you for your attention.
So would you like to sum up?
Yeah, just hope you all enjoy this session by Dr. Naveen Jain sir on a comprehensive session on the simple tools for the pediatricians, how to detect developmental delays or deviations in the office practice. And equally, simultaneously, he addressed after detection, how to address the issues, how to counsel the parents, how to organize the follow clinic. The most important challenge is to get the parents back to the facilities for the development and how to help them. So these are all comprehensively discussed. I will suggest to go for the summary in different regional language. Then I will take the questions, if anything, specific challenge in the local areas and local hospitals with different facilities, challenges are different. If anything, real difficult situation, scenarios, we can discuss here, few practical tips. So open for the summary session.